Good day. My name is Scott Harris, and I'm the Chief Medical Officer of AltImmune. We're a public biotech company in the Washington, D.C. area of the United States. So with regards to obesity, we need to clearly identify drugs that are going to reduce cardiovascular risk, and also drugs that are going to maintain lean body mass and body composition. We know from the SELECT data that semaglutide, which produced about a 16% weight loss over the course of the year, was associated with reduction in cardiovascular risk of about 20%. There is the opportunity of greater risk reduction. Semaglutide has very little effect on serum lipids, and the same would apply for tirzepatide. And if we are able to achieve these effects on lipids, such as LDL cholesterol and total cholesterol, we'd even have a more robust effect than we've seen due to pure weight loss alone. We also don't know a lot about the lean loss that these drugs induce. We know that, for example, semaglutide had a 40% reduction in lean mass over the course of 72 weeks. But that was also associated with a higher risk of fractures in women and the elderly, and lean mass itself is known to be inversely correlated to function as well as mortality. So we need to know how these drugs affect lean mass. We know how to study that better and provide for drugs that preserve lean mass for preservation of function over time. With regards to MASH, we have an initial approval, at least in the United States, of resmetirom for NASH. And while the effects are significant, the magnitude of the effects are not that great. So we need more potent drugs for MASH. And in addition, we need not only drugs that reduce the actual pathology of MASH, the NASH inflammation and the fibrosis. We need drugs that simultaneously also reduce weight, because the major comorbidities of subjects or patients with MASH is not the liver disease, but certainly in the early to mid stages of the disease, it's the cardiovascular comorbidities due to the obesity. So it's critical to have drugs that treat both weight loss and MASH in the treatment of MASH. And right now we don't have that. Well, we certainly have robust evidence in obesity. We have two drugs that are approved in the United States and Europe for the treatment of obesity, and that would be semaglutide and also tirzepatide. And these effects are very robust, much greater than have been seen in the past with earlier generations of drugs, achieving or exceeding 20% weight loss in the course of a year and a half. And there's a current effort right now to add additional agents to these drugs, either as separate agents or combined as co-agonists within the same molecule in order to increase that effect. Now, there are no incretins currently approved for MASH, but we have recent data with tirzepatide and also survodutide that these drugs can be very, very effective in MASH as well. We're not seeing really robust reductions in liver fat enough to really move the needle in MASH, and we're looking forward to having more potent liver defatting drugs as we move further into development. So, as I mentioned before, we don't have a lot of data about loss of lean mass. And we also don't have data regarding the long-term use of these drugs. We know that when these drugs are stopped, that the weight accumulates back, and in fact, the weight that accumulates is more fat than it is lean. So in a subject that's taken a round of GLP-1s and then loses the weight and then regains it, they're actually worse off from a point of view of body composition. So we clearly need to understand how these drugs affect body composition, how body composition affects function. We know that it has an effect on bone fractures. And importantly, we only have acute data. We know about weight loss over a year, but we don't really have the kind of data that we need to follow patients over a long period of time and know how these drugs work chronically. Currently, all the focus of these drugs is in weight loss over a year, but that's not where the real need is, and that's also not where the market will eventually be. The market will eventually be long-term treatment of obesity. It will be weight management, not weight loss. So the weight losses that we're seeing acutely are important, but they don't say anything about weight management, either the magnitude of the weight loss or the safety of the weight loss. In addition, we need further research into market segment. The obesity marketplace is not differentiated at the current time. We have a knowledge of weight loss, that's really about it, but there will be different patient phenotypes that will need different drugs. Some will need pure weight loss, some will need liver fat reduction, because they also have MASH, but also liver fat drives cardiovascular morbidity. Some will need reduction in serum lipids. In addition, we also have to have drugs that preserve lean mass, and that's going to be critical. We recently released data that we have class-leading effects in preserving lean mass amongst the incretins. So that's the kind of research that's needed. The long-term effects of these drugs and the actual market segments and patient phenotypes that will evolve over the course of time. Well, the current compliance rates with GLP-1s have really not been very spectacular. We know that a large number of patients discontinue their drugs after a short period of time. I recently heard data that only 30% of these patients maintain their drugs over 3 months. So right now, these drugs are used for acute weight loss, and possibly the majority of people who are trying to achieve cosmetic effects of the drugs. What we need is commitment to long-term therapies that have meaningful effects long-term in changing the natural course of obesity and its comorbidities. So the challenge will be chronic therapy, both in the minds of patients, but also prescribers, to maximize the effects of these drugs over a long period of time. The issues in MASH are a bit different. In MASH, part of the problem is that we're relying very much on a liver biopsy to guide therapy, and the non-invasive markers have not been fully mature. We are better and better able to identify patients at risk without a liver biopsy, but it's not an exact science. So consequently, more research is needed, and there are challenges in identifying the patients or the subjects in trials that are best suited for certain types of therapy in MASH. All in all, the marketplace is going to be differentiated over the course of time. Dr. Lou Aroney at Weill Cornell has indicated that obesity is the new hypertension. Back in the 1980s, we had very, very poor drugs for hypertension, and now we have 10 different classes of antihypertensive drugs, and the market is mature. Obesity is not a mature market, and the focus right now is too much on acute weight loss. So over the course of time, several important things will happen. Number one, the market will differentiate to identify phenotypes of patients needing specific classes of drugs. We firmly believe that our compound, which has glucagon in it, and that's pemvidutide, will achieve its own market segment, particularly for preservation of lean mass in susceptible individuals and individuals needing greater loss of lipids because of the potent effect that glucagon has on serum lipids. So we're really looking forward to the market maturing, and we're also looking forward to the clinical trials that will identify these needs and get us there.